just so we can get as much done in an hour as possible. Why don't we go ahead and we'll get started? And I know people will be continuing to join in, but I am Dr. Bob Jones from Metro Health Hospital in Cleveland, Ohio. And I want to thank EchoNews for hosting these VExUS webinars. This is now the second one in a series with more coming. And I'm excited that we've got such an incredible group of faculty here to speak. First we have Phillipe Rola, who's a pulmonary critical care physician and ICU chief at Santa Cabrini Hospital in Montreal, Canada. He's an MCRIT teammate and is very active on Twitter. If you're not following him at Thinking CC, you should go ahead and do that. He also has a phenomenal website, thinkingcriticalcare.com. And of note, he was a member of the team that did the initial work on VExUS and creating this sonographic protocol to evaluate venous congestion. Next, we have Dr. Abhilash Koratala, who is an academic nephrologist at the Medical College of Wisconsin and is a leader in bringing POCUS to the nephrology community. A lot of you may know him better as NephroPOCUS. And you can find him on Twitter as NephroPOCUS. And if you're not following him, you absolutely should. He also has a phenomenal website, nephropocus.com. And last we have, but not least, Dr. Katie Wiskar. She is an academic internist practicing in Vancouver, British Columbia. She completed a POCUS fellowship at University of Western Ontario's Critical Care Ultrasound program. And she currently practices at Vancouver General Hospital and leads the IM POCUS program. Her website, ubcimpocus.com, is also phenomenal for everything POCUS. So if you have not found that, you definitely should. The lectures she has there, as well as her teammates there, are phenomenal, including her venous congestion lecture. And you can follow her on Twitter at Katie Wiskar. So again, we're excited to have this webinar. And again, thanks to EchoNews for this. So we're going to be starting first with Dr. Rola, who's going to be presenting a case here. So we'll turn this over to you now.
Thanks a lot, Rob, for the introduction. Small detail, I'm actually an internist, not a palm guy, but no worries. All part of the same team. So apologies to everyone. I unfortunately, our hospital network internet is kind of half down, so I have to run this off my phone. So I'm going to go about this case that was actually a case from yesterday. Turned out to be one of the interesting ones. And I thought that I'm sure everyone who's following POCUS, VExUS, et cetera, is used to seeing these perfect images on these easy patients, so, and it might be sometimes frustrating to show how sometimes it's not so easy, but you still can use, elements of it to make a decision. So this was a lady who came in day before yesterday with a shortness of breath, hypoxia, hypercapnia, et cetera, and was sold as a COPD exacerbation, maybe with some CHF because her BNP was elevated. And so she came into the ICU because she was on BiPAP. And let me try and see if this is going to work. I'm going to share my screen. And she came in with both acute kidney injury and with there we go. Let me just pause that. Came in with acute kidney injury and hypercapnic respiratory failure. She's a big lady and massive anasarca. And so she had an angioscan, and right away on the angioscan, I could see that the angioscan was quote unquote negative, but it was positive for a lot of other things. There was a little bit of, maybe some atelectasis or maybe small pneumonia at a base, but there wasn't really much pulmonary congestion. But the PAs were huge, pulmonary arteries were big, the RV was big, the IVC looked big. So this looked to me like, there's certainly some right heart disease. So let's see what we can see here. This is a terrible view on the short axis of an IVC. You can kind of make it out to bottom right. It's big, it's not moving, but it's a terrible view. Here's as best I could get of a 4-chamber, and you can see on that one that the RV was a little bit bigger, if anything, than the LV. So the ratios are all off. When I look at the TAPC is under 2 centimeters. And then here now, here's a color look at her portal vein, and we can pretty clearly see that it's pulsatile. And when I put the Doppler on it, we can also see there that there's definitely some good pulsatility there, and you can even say it's 100% or a little bit even more, as we got a little bit of signals under the baseline. So pretty pulsatile. And that's, again, that's a still shot of the portal vein pulsatility. And that's where we were on that at that moment. So her creatinine, in our SI units was about 200. There wasn't really a baseline available. And so she had gotten some Lasix, but she had dropped her pressures a little bit. There was worry about her creatinine, so she came into the ICU. 200 is about, a little bit more than double normal. So that's where we were. And I had to make a decision based on this information. So in my mind, this was a patient with clear right-sided heart failure with 100% portal vein pulsatility. There was no way for me to get intrarenal looks, and her hepatic veins were hard to get reliable because she was breathing, quite fast. So essentially, this was essentially what I was limited to. But to me, I had a plethoric IVC, pulsatile portal vein at 100%, which essentially gave me a VExUS 3 physiologically, even if I didn't have the rest of the information. So I went ahead and diuresed this lady with a double normal creatinine who had dropped her pressure before. So let's see what the next day showed. So the next day, there's a little less portal vein pulsatility. And we can see here that we no longer have 100%. There's a couple of respiratory motion there that looks like it interrupts, but that's essentially what we got. Now, what I also did in her case was to start her on vasopressin in order to limit the blood pressure drop that might happen by getting lots of diuretics. All right, let me just stop sharing. All right, so essentially, this lady's creatinine normalized. Her blood pressure stuck around between 110 and 130 with a little vasopressin. Turns out handy because vasopressin's got a small, a small pulmonary vasodilatory effect as well. And her creatinine entirely normalized today, and she's, feeling better, and she's -5 liters. So I think to me that's a nice little case example on how, when you know that you have a strong risk of congestive nephropathy, you can feel pretty comfortable in pulling off fluid despite an elevated creatinine. So that's my case for today.
Let me check into the chat. If anyone has any questions, go ahead and put them into the chat. In the meantime, Dr. Koratala, do you want to go ahead and do your case?
I think you're muted, Abhilash.
Sorry, I was just asking if my screen was visible completely, or is it in some presentation mode or something like that?
You're in presentation mode, so we can see your notes and stuff on the side.
Okay, let me swap it. How about now?
There you go. That looks better.
Okay. Okay, very good. So Dr. Rola has talked about an acute case where VExUS has helped in formulating a management plan. But I'm a nephrologist, so I don't see acute cases that much. And I'll say I'm nephrologist and also internist. So our goal is mainly to see like how the patient is progressing once we diagnose a patient with congestion, and use VExUS as a monitoring tool and essentially see what's the response of these waveforms to decongestive therapy. And based on today's cases, I just have two cases, one small case and one little longer. And based on these cases, I want to demonstrate that these waveforms are dynamic. And you put more fluid into the body, these waveforms change for the worse. And if you remove fluid, they change for good. And that way, we know how much fluid to remove, how much fluid to remove during dialysis, or how to titrate the diuretic therapy, and when to discharge the patient, and what to expect, and what if the IVCs chronically begin some patients, and is there some other reliable parameter apart from IVC? So with that understanding, we'll move forward. So we had this elderly patient with known systolic heart failure. Ejection fraction was less than 20%. She was seen for acute kidney injury, and serum creatinine was 1.8 from a baseline of 1.1, and NT-proBNP was 8,118, and the last available proBNP was somewhere around 10,000. So the BNP was lower than what it was before, and the patient had only trace pedal edema, which was chronic for her. So the admitting physician thought the patient was volume depleted and over diuresed, and that's why the creatinine has gone up. And apart from lower NT-proBNP, the other reasons were that patient was not really overtly symptomatic, and also during last admission for heart failure exacerbation, her diuretic therapy was intensified. So that was another reason to assume that the patient was volume depleted. But the renal function was not improving after they gave intravenous fluids, and the patient was already developed a positive cumulative fluid balance of 3 liters. That's when nephrology saw her, and we performed physical examination. So this is how her heart looked like. And as you can see, there is severe LV systolic dysfunction. And here you can see left pleural effusion nicely, which is posterior to that of descending aorta. And here is the parasternal short axis view, where again, you can note LV systolic dysfunction. And also you can see that there is some flattening of the interventricular septum, suggestive of volume overload when it's primarily in diastole. And still you can see the left pleural effusion. This is parasternal short axis to RV inflow kind of view. From the parasternal window, trying to look at the tricuspid wall. So there appears to be some regurgitation, at least moderate, looking at it qualitatively. And here is her IVC. So IVC is big, definitely more than 2 centimeters and barely collapsible. We looked at it in both long and short axis. So the next step is to do the VExUS assessment. And a gentle reminder before we go, for the benefit of our beginner audience. So as the right atrial pressure increases, this is how the hepatic vein changes. Initially, in the normal state, the systolic wave is greater than the diastolic wave. And as the RAP increases, the systolic wave becomes smaller and smaller. Ultimately, it reverses and goes above the baseline. And portal vein, normally it's not pulsatile, it's relatively continuous, or pulsatility is less than 30%, and the RAP increases, the pulsatility gradually increases. It reaches 50%. That's when you call severe congestion, 50 or more than that. And ultimately, there will be flow reversal. That's very severe elevation in RAP. And intrarenal waveform, in normal state, it's relatively continuous, like portal vein, is just below the baseline. And as the RAP increases, the pulsatility increases. And at one point, you will see distinct systolic and diastolic waves. And finally, only D wave remains below the baseline, and the systolic wave reverses. And if you are able to get an isolated venous tracing, you'll see the reversed S wave. If not, it will just merge in the arterial waveform. So this is how venous waveforms change. And let's look at her VExUS. So you can clearly see that there is only D wave below the baseline. So this is D only pattern or severe congestion. So S wave has already reversed. And here is the portal vein. It is 100% pulsatile. You can see gaps there between these mountains. And there is also some flow reversal that is below the baseline flow. So that also indicates severe congestion. And so obviously it's VExUS grade 3 or severe congestion. So we intensified her diuretic regimen. So we followed up 3 days later, and the serum creatinine trended down to 1.2 milligram per deciliter. Remember, previously it was 1.8. And the cumulative fluid balance was negative 253 ml. It's not a lot of negative, but initially she was positive by 3 liters. So taking that into consideration, we removed quite a bit of fluid. And the hepatic vein, still it's deep prominent, though above the baseline waveforms, it seemed to have decreased a little bit, but still it's considered severe congestion. But portal vein has nicely improved. Now there are no longer gaps between these mountains or pulse tail flow. All the complete waveform is above the baseline, and the pulsatility is probably somewhere around 40 or 50%. So it has considerably improved. And then we followed up on day 5, and the serum creatinine was completely normalized. It was 0.9 milligram per deciliter, and the cumulative fluid balance at that time was negative 1.3 liters. And you can see in the hepatic vein waveform that the S wave was nicely coming below the baseline, though there is still S less than D pattern. And we never know if this S will ever normalize or not, because the patient has pre-existing severe systolic heart failure, both left and right sided. So S wave depends upon how well the right ventricular systolic function is. So it might never normalize. But you can see the portal vein on the right-hand side of this slide that it has almost normalized. The pulsatility is less than 30%. So now you know that you have done a nice job with your decongestion, and creatinine coming back to baseline is a proof that the congestive nephropathy has improved. So in this patient, we did not have renal waveforms. Renal was very difficult to get in this patient. If you want hepatic tracing with EKG, I have done with my other portable machine also with EKG guidance. And this on day 5, you can see nicely S and D waves. S is following the QRS complex. So this interpretation is accurate, that S wave is smaller than the D wave. And nicely looking at the parasternal short axis view, previously I showed that there was significant interventricular septal flattening. And after decongestion, the flattening has improved and LV has become almost round. So that's also a nice indicator that you did a good job with fluid removal. And this was her IVC on day 5, and it's still big, and the hepatic veins also seem big. In comparison, this was the initial IVC. So compared to initial IVC, it appears slightly supple and maybe a little bit reduced in diameter. But when different people are seeing patient on the floor, hospitalists are changing, residents are changing, it's very hard to compare from before, like your findings with prior reading, unless you have these tracings, which makes it much easier to compare. And her IVC, like I said, might never normalize. So that's case 1. So based on this case, you know that with fluid removal, physiology changes. And going to the next case, which is last case, but I have several follow-ups on this case. So here we have this elderly patient who had complicated vascular surgery and prolonged hospital stay. And he developed AKI stage 3 on chronic kidney disease. That means he required dialysis during the course of hospitalization. And when I came to service, I was told that the patient is not tolerating ultrafiltration, not more than 1 liter during the past few dialysis sessions. Overall, the patient was thin. He had abdominal, sacral, and lower extremity wounds, partly from vascular surgery and also pressure ulcers and all those things. There was no ankle edema, and it's hard to assess sacral edema in this patient. And the patient also got some paroxysmal atrial fibrillation with intermittent rapid ventricular response. And the blood pressure was slightly on the lower side. So on that particular day, documented fluid balance was positive 12 liters from the day of admission, or last 30 days. And the documented weight was 77.4. And on physical examination, that is POCUS, looking at the heart, the LV ejection fractions seems okay, maybe slightly reduced. RV is also moving, not horribly dilated, but probably systolic function is slightly reduced based on visual assessment of how the tricuspid annulus is moving. Actually, I measured the tricuspid annulus S prime. It was about 9 centimeters per second. So it was slightly low. And there is some tricuspid regurgitation. It doesn't seem to be too bad. And IVC was big, more than 2 centimeters and barely collapsible. The patient was spontaneously breathing, though he had tracheostomy. And so looking at the hepatic, as expected, it's it's only D-only pattern, that is severe congestion. And on color, you can see one red and one blue, as Dr. Rola describes. It's polysiren sign of color VExUS. Anyways, it's severe congestion, and you can also see this on EKG based machine. So there is only D wave below the baseline, and the heart rate is irregular, suggestive of atrial fibrillation. And the portal vein, it's 100% pulsatile, and there is some flow reversal. And intrarenal vein, there is only D-only pattern, that means only D wave below the baseline. And the above the baseline tracing is actually venous tracing. So you can see the S wave reversal above the baseline. So ultimately, you put all these things together, the patient has severe venous congestion, though nobody thinks there is severe, though it's not expected based on general physical examination or general look, the way patient appears. And okay, so obviously I changed the patient from intermittent dialysis to continuous renal replacement therapy and started pulling off fluid. And this is the first follow-up exam. The documented fluid balance was negative 2.25 liters compared to previous exam. And weight reduced from 77.4 to 74.1 kg. So there was loss of fluid and also reduction in weight. That's a good thing. IVC is still big. And here is the hepatic. It still demonstrates D-only pattern, though above the baseline pattern seems to reduce a little bit in terms of amplitude, though it's hard to compare unless you're measuring at the same site and your angle is correct. Anyways, it still shows severe congestion, but the portal vein here seems to improve nicely. Previously, it was 100% pulsatile, and this one is about, say, 40 to 50% pulsatile. So that means it's improving. So we are doing a good job with fluid removal. And the renal is still D-only pattern. And as we have been seeing, renal takes a little longer time, possibly because of interstitial edema. It usually lags behind other waveforms. And here is follow-up too. So we continued CVVH, continued pulling fluid. So now by this exam, the patient was net negative 4 liters compared to previous exam. And the weight has dropped from 74.1 to 71.4 kg. The IVC is still big. And here is a hepatic vein. So this is the color hepatic vein. Here you can see more blue. That means there is something good happening. And it's still D-only pattern. By definition, it's still severe congestion. But above the baseline component is significantly small compared to previous exams. And here is a portal vein. It almost normalized. The pulsatility is pretty much less than 30% or close to 30%. Though the renal still remains as monophasic as D-only pattern. Like I said, it takes a little while. Okay, here is our follow-up 3. So continued CVVH, continued to pull fluid, and here the net fluid balance was negative 3.3 liters, and the weight has further reduced to 68.4 kg from 71.4. The IVC is still big, but in the long axis, you can see that it appears little more supple, not as plethoric as before. And here is the hepatic vein. It's more blue now, and you can see that little S wave has started to appear below the baseline, though it's still deep prominent. And here is the portal vein. It's nice and continuous like the previous exam. And here is the intrarenal. So it's still deep prominent, but you can see that S wave has started to appear below the baseline, at least in some cardiac cycles. And here, the above the baseline tracing is the arterial waveform. That's how we know what is systole and what is diastole. And follow-up 4, here, there was some issue. The patient received some fluids because of hypotension. So ultimately, the patient was now positive fluid, in positive fluid balance compared to prior exam, but not a lot, 100 cc. And on that day, when I was performing follow-up exam, it was positive 700 cc. And the same day they obtained cardiology, performed echocardiogram. There wasn't much change compared to prior exam that we saw. EF was slightly low, 44%, and with an estimated stroke volume of 67 cc. And RVSP was 52, taking right atrial pressure as 15. and there was mild to moderate TR, and tricuspid S prime was 9 centimeters per second, which was exactly same as what I got in the initial exam. So the weight was pretty much unchanged, and the IVC was still bigger. And hepatic vein here, it seems to be slightly worse compared to prior exam. In the prior exam, there were more prominent S waves coming below the baseline, but still, or more or less, you can say it's pretty much similar to that of prior exam. And here is the EKG image with EKG. Here you can see that the wave that is following the QRS complex, that is the S wave, is smaller than the D wave. And portal vein, it's again like becoming a little more pulsatile compared to previous examination because the patient is now in positive fluid balance, though it's not bad. And renal is again predominantly monophasic or demonstrating D only pattern. So basically we saw that with fluid removal, it improved. And as the patient is becoming more positive, they are slightly dwindling and becoming a little more pulsatile. And this is the fifth follow-up, and the documented fluid balance was, again, now it's better. It's negative 1.4 liters compared to the prior exam, and the weight has dropped. The IVC is at least 2 centimeters, but you can see it's not as plethoric or plump and non-collapsing. It's still less than 50% collapse, so your estimated RAP is still 15 mm mercury. And here is the hepatic. There seems to be some S waves coming below the baseline, but still predominantly D wave pattern or D only pattern. And the portal vein has, again, from slightly pulsatile to it has become continuous now with negative fluid balance. And here is follow-up 6, and I did not do renal at that time. And now this is remarkable. At this exam, the documented fluid balance was negative 5 liters compared to prior exam. And the weight was 63.2 from 64.9. I mean, weight doesn't seem to correlate with how much negative the patient is, but that's a problem. They don't always correlate, and there can be some discrepancies in the documentation. The IVC is still on the bigger side, and here's a hepatic vein. It seems to be almost normal. The patient is in sinus rhythm, and it appears to be pretty much normal waveform to me. I mean, there is slight possibility that the smaller wave might be S and this might be D. Without EKG, it might be very difficult to say, but I would still take it as normal. And here is the portal vein. It's pretty continuous as expected. And renal, you see nicely S and D waves both are below the baseline. You see why I say the hepatic is little doubtful, because generally we tend to assume that when the waveforms are continuous, we assume the initial waveform is S and the next waveform is D. But here you can see in renal, like, see this wave, like D and S, they seem to be pretty continuous. That's why I say it might be difficult without EKG, but it doesn't matter. Who cares? I mean, both S and D are below the baseline. It's very nice compared to the previous one. It pretty much improved almost to normal. So the last follow-up 7. So now the patient, again, they did something with the patient, gave fluids and all those things, and changed continuous renal replacement therapy to intermittent because it was interfering with physical therapy and they want to discharge the patient. The regular things that happen in the hospital. So the weight has also gone up. The IVC is big again. Now the hepatic has worsened. It's only D only pattern now. So you pull fluid, it gets better. You put more fluid, it gets worse. And portal vein, again, it's 100% pulsatile. So whatever we did, all the work so far is wasted because the patient got more fluids. And here renal, again, it's only D only pattern with S wave reversal. So it's worse congestion. Okay, so this is the last follow-up. So after that, again, there were some changes. We increased the ultrafiltration, asked to give pressors as needed. The patient was put on midodrine and all those things. So in the final exam, the documented fluid balance, when I saw, was positive 17 liters compared to previous exam. Nobody knows if it's true or not. And the weight, actually, the documented weight was lower than before. It went down to 62.2 from 66.2. So definitely that positive 17 liters is wrong, but I assume that he had some positive fluid balance. So I'm just highlighting that documentation is not necessarily accurate. It depends on if the patient is moved rooms or changed floors and all those things. So IVC is still big. It's about still 2 centimeters. But we've been removing fluid with dialysis. So again, like S wave seems to come below the baseline. though it is still D predominant. So despite that horrible looking documentation of positive 17 liters, the waveforms are showing a better change or positive change, which shows that, these don't lie. So when you're in doubt, you can use these waveforms to confirm the accuracy of documentation. And the portal vein, it's not normal completely, but it's still much better compared to previous waveform. Previously, I showed it was 100% pulsatile, and now it's maybe about 50% pulsatile. And renal, there appear to be more, it's still D prominent, but there appears to be some S wave below the baseline. So it's improving. If the patient remains in the hospital, I'll continue to follow. But for now, that's it. Basically, I wanted to make a point that these waveforms are very dynamic, and I hope I made that point. So thank you.
All right, thank you for those cases. Why don't we go ahead and take a look in the chat for some questions here. So Tom Jellick asked, when patients start dropping their blood pressure as you diurese, do you just sit tight assuming the patient is mentating and has normal perfusion, or do you add vasoactive agents? And if so, what is your vasoactive agent of choice?
That might pertain to my case a little bit. I think it's always going to depend on each patient's individual hemodynamic. So, if I'm working with someone who's, got pulmonary hypertension, and what I want to make sure is that they don't lose too much preload, and I feel they have recruitable preload, I'd probably go with vasopressin like I did in that case, because we've got a little bit of a pulmonary vasodilator effect. And that can help, knowing that there's no, inotropy that's provided. If I think I need more inotropy, then I probably would just go with some levofed or something like that to keep the pressure. But it is true, and it's something to keep in mind, that if you've got someone with marked pulmonary hypertension, they will most likely drop their pressures when you're diuresing them aggressively, if you need to take a lot of fluid off. Sometimes you don't. But in the example with my lady, she was clearly about 10, 11 liters over. She big swollen legs, a lot of just even dependent edema on her trunk. So she needed a lot of fluid off. So that's why I went that route.
All right, thank you for that. Why don't we do the next another question here? Why don't we do a simple one here, a quick one? What probe do we all agree is the one you need for a VExUS exam? I'd say phased.
Yeah, I think a phased is great if you have it, because as Abhilash has showed us, the ability to add ECG gating is super helpful. But I do find if I'm trying to get the renals, especially, then a curvilinear is better for that. That being said, you've seen that many of us often can't get the renals, but if you just have one, a phased is sufficient for sure.
Agree, curvilinear works best for renal, and with phased, renal blood flow pickup is not at all good. And yeah, but otherwise, like, phase seems to be fine.
Okay.
Agree with that.
How about, do you use VExUS in your chronic dialysis patients with impossible physical exam, forever struggling with fluid balance and target weights?
I recently started using it, but one problem is that we don't have machines in the dialysis unit. If at all we do have, they are just restricted to having a vascular probe. So after I started using Cosmos, I started doing some VExUS on dialysis patients. It's almost impossible to get renal waveforms, but at least hepatic and portal waveforms. I started titrating ultrafiltration or dry weight based on that. And I cannot say what are the long-term outcomes and stuff, because I go to dialysis unit maybe once or twice a month. So I've been using only for the past few months, and I found it helpful and it is doable. I'm just learning my dynamics, like how to sit there and get the waveforms without breaking my back. As you know, the dialysis chairs are not the most comfortable things to do VExUS. Yeah, but they can be used. And I even published a case report that these waveforms change in dialysis patients. That's for sure.
I think that's an interesting question, though. And Abhilash, you have such a good patient population to study this. And I wondered, even as you're presenting this case, are normal waveforms the target in everyone? I don't think they are, probably, in some people who have other concomitant cardiac pathology. So it's interesting then, like, what is your, like, for that case you presented, was your endpoint, like, were you trying to diurese to normal VExUS waveforms? Were you diuresing to creatinine, to physical exam? I would imagine a combination of all three. But I suppose they're a useful point to follow, but not probably the only thing that you're following in those cases. Is that fair?
Exactly. I mean, it's always a multi-point thing, whether it's dialysis patient or not. So, I mean, in both those cases, IVC was still big, right? Like, it's not going to give much information. And I mean, you don't want to diurese so much that you reduce the preload and ultimately you reduce the forward flow. And same applies to dialysis patients. Yeah, that has to be studied. For now, the data in the dialysis patients is all about lung ultrasound. But I think adding VExUS is definitely adding a very important data point that you can follow, because lung only tells you about the left side of the heart, and which you may or may not be able to address during your 4 hours of dialysis and ultrafiltration.
I guess one other question for you, Abhilash. As you start to do more of these, I know you said you do VExUS clinics. Are you taking your patient population and obtaining baseline kind of waveforms on them when they're euvolemic, so you have something to compare it to, that maybe when you are kind of looking for where do you go, where do you stop, what's their ultimate endpoint? Have you done anything on those?
I mean, my POCUS clinic is not for dialysis patients, because we don't typically see dialysis patients in the clinics, because we go to them and it's very difficult for them to make time, because they go to dialysis 3 times a week. So my clinic is mainly for chronic kidney disease patients who also follow up with cardiology. And it's interesting that some of them have this pulmonary artery remote monitoring, and cardiology documents something in the note that the pulmonary artery pressures are high, and that way I get to see how it's really correlating with the venous waveforms. Yes, I put my examination in my note, and when I see the patient again, I'll do a follow-up exam. And so far I have good success in titrating the therapy based on portal vein waveforms. Because most of them have like chronic pulmonary hypertension. It's very hard to depend on renal. Most of the patients just tend to have like biphasic renal vein waveform almost permanently. But yeah, portal is good to follow and titrate therapy.
Okay, thanks. Next question, does Afib affect the interpretation in any way?
Yeah. I mean, like we did this question previously, and in hepatic vein waveform, it's always good to have simultaneous EKG, because one thing is, if the rhythm is irregular and the shape and rhythm shape of the waveform and the rhythm change, and also the hepatic S wave is partly dependent on ventricular contraction, that is when the atrium is relaxing. So atrial fibrillation affects atrial relaxation. So the S wave can be smaller than D wave at baseline. So that's one problem with that.
Okay. All right. Next question. I think, Katie, you were going to answer this one. I think, granted that a plethoric IVC is supposed to be the starting point for a VExUS scan, how often do you find discordance between any 2 parts of the scan, such as a normal IVC, but the patient still has pulsatility in the portal vein?
Yeah, I think that, I mean, I know Phillipe said over and over that a congested IVC is like a prerequisite. And if you don't have that in terms of VExUS, like do not pass go, do not collect $200 kind of thing. That being said, I think especially as you're gaining practice, it's useful to try to collect other waveforms, because sometimes they can act as a nice check on each other. And if I have really discordant findings, I'm going to make sure that I really believe my findings, right? Am I actually seeing this IVC properly, or is there some, lateral translation that is tricking me into thinking that it's collapsing, for example, or is there intra-abdominal or intrahepatic pathology that's confounding things? The other thing that you mentioned specifically with the portal vein is that there's literature to show that you can get portal vein pulsatility, not reversal of flow, but pulsatility in normal, thin, healthy patients. So that certainly could be, you could have a plethoric IVC, but a collapsible IVC rather, and a pulsatile portal vein in someone who is totally healthy. But I think in general, you want to see a congested IVC before you go further. But do your waveforms, make sure you believe what you're seeing. If you don't believe, then take everything with a grain of salt, I guess, with regards to your scans, because there's caveats to all of these waveforms, as we've talked about.
Okay. Also, I was going through your cases, Dr. Viskar. I mean, I was just browsing through Twitter, and I saw where you shared a case of a very young patient who received fluids in the ED, and the IVC was big, and the portal vein was pulsatile after just 1 liter of fluid or so. I think William was commenting that we don't know how these waveforms behave immediately after fluid administration. Totally. I found that's very intriguing. Totally. I don't know, like if you had a chance to follow up.
I did. I think COVID hit, so I didn't see her in person, but I followed up with her remotely, and she had an echo. And everything was like stone cold normal, and she was totally fine. So I assumed that was like the transient effect of like the liter of fluid she had, which is kind of crazy to think about, that you could generate pathology so easily. So I don't know. Someone needs to study it. Someone needs to get a bunch of med students and give them IV fluids and then scan them.
I guess as a little takeoff on that question about the discordance in findings from one waveform to another. Another question that this was emailed in was, do you find commonly differences between left and right kidney, and how do you then reconcile between the difference?
I mean, I don't always compare right and left kidneys for the most part, but if you look at the literature, generally they say they choose right kidney because the left renal vein passes between superior mesenteric artery and aorta. I'm not exactly talking about nutcracker phenomena, but it's something like that. So the theoretical premise is that maybe that has some effect on the waveform. So right kidney is generally studied. And also it's much easier to find the right kidney and get a better flow than the left kidney, because left kidney, you can have bubble gas interference and the Doppler can get crazy. So, and also like when you compare both the kidneys, it's very hard to get your Doppler gate at the same vessel in the both kidneys, right? Those differences have to be taken into consideration. So I really don't know what's the answer. And I also don't know like if it is like practically significant, like is it really going to change our management or interpretation as a whole?
I think most of us consider ourselves lucky if we can find one kidney waveform. If I get a kidney waveform, I just stop and celebrate. But yeah, no, I think I almost always just scan the right, and I'm almost always standing on the right side of the bed. So ergonomically, it sort of makes sense. So I can't really comment on having compared them a lot in the past.
Okay. And I know, Abhilash, you published a couple cases on Twitter where you've shown the splenic vein. When do you decide to incorporate the splenic vein?
It's not a routine, but in general, like if I cannot get a good portal vein waveform, or in some patients, if I cannot get renal and portal vein is little dubious, like say, I'm not able to get a good straight segment, but sometimes pulsatility, when you're assessing qualitatively, it can look a little tricky when you don't get a straight segment. And when you compare like the main portal vein with one of its branches. So when something like that doesn't correlate or I don't feel confident, then I look for splenic vein. As far as I saw, like they both correlate really well. But I think William and Bubin and his team is doing some research on splenic vein, and they seem to have some discordant findings, which hopefully will be published. But so far, as of I saw, like they seem to correlate.
Okay. Here's a question from Chile. When you have a patient in the ICU with septic shock, AKI, and you obtain a VExUS and the score is grade 3, how do you indicate, I guess,
I think that's supposed to be what's your furosemide like strategy. I think that's what they're saying there.
Okay, furosemide stress test. Okay.
So, I mean, it has two parts, right? So basically you're saying the patient is congested, no matter what it is. It could be because of over resuscitation or something else. The heart is not working well, septic cardiomyopathy or something like that. And once the patient is congested, you have to decongest the patient. So you give a higher dose of furosemide. Definitely it would be more than that 1 milligram per kg. And the second part of the question is about furosemide stress test. So in furosemide stress test, what you're trying to do is if the patient responds and makes urine, it is an indication of functioning tubules. Probably there is not much of a ATN, and it's maybe more hemodynamic component to the acute kidney injury. That's what it's going to tell you. Apart from that, I don't think it's going to really change any more management. And if the patient is not responding to diuretics, like such a good dose of diuretics, it's most likely tubular injury. And you can obviously have tubular injury and venous congestion together. And actually, like if you have tubular injury, that predisposes you to having more venous congestion because you're not able to excrete urine. So I hope that answers the question. So basically, these two things can coexist. Hemodynamic or congestive acute kidney injury and ATN can coexist. And if they respond to diuretics, that's great. If not, do ultrafiltration.
Okay. Does anyone have any insight to potential VExUS CME courses?
Well, we are setting up a VExUS course in September, which is going to be a didactic plus long workshop. And we're still up in the air whether or not it's going to be CME because of all the difficulties related to setting up CME events. So possibly. Otherwise, at HNR 2022, for sure, there's going to be one that will be CME.
Okay.
So I assume it would be in Canada, right?
Yep.
And hopefully in person, COVID permitting.
Hopefully.
Fingers crossed.
Has the border opened up yet? I don't even.
It's open, but there's still quarantine things, which is why initially I was going to hold a live event in September, but it's still not 100% clear. So I think we'll bump it to next year and stay virtual for a couple more months.
Mm-hmm. Next question is about billing for ultrasound scans. Does everyone here bill for them? I know we do.
I think that's probably super, practice dependent and country dependent, because I presume that your practices in the States are quite different than ours and our billing up here. Our group has, we have a consultative POCUS service that services our internal medicine, hospitalized patients. So we see patients in consultation and do sort of a whole consult with POCUS. So we bill consults like that, but not specifically just for the ultrasound. So I don't think in Canada that exists yet. And then the other part of that question, I think, was related to would radiology do these scans? And I can't say that I've ever talked to anyone from radiology about VExUS. I haven't seen someone be interested because it really is kind of like lung ultrasound. It's something that, radiology never really owned before. It belongs to POCUS, at least right now, because ultrasound techs don't do these scans. They do some of the individual parts, but they don't integrate, the IVC and the hepatic and portal and renals and the heart image and provide you with a clinically integrated picture, which I think is the value of VExUS.
Yeah, and also it's hard to order multiple scans every day, right? So
yeah, you can get radiology to come by every day and do the IVC, the hepatic, the portals, the renals every day.
Yeah, at our institution, we bill for all the POCUS studies. And regarding VExUS, I don't know for sure because I recently started billing. There's a code for that, 93976, which says duplex scan of arterial inflow and venous outflow of abdominal and pelvic contents. So that's what I was, that's what our coder started using. They said if the insurance, there are a lot of denials, they'll let me know, but so far they did not. So I'm hoping that it's going through.
All right. Next question is, do you use VExUS for a neuric acute hemodialysis patient with AKI due to presumed ATN? And do you think that renal recovery is less likely or delayed if VExUS is not normalized?
Yeah, I do think so because, it's an assumption. Obviously, there is no, hard data on that. But in general, we know that if somebody has AKI, you try to minimize all the nephrotoxins. And venous congestion is a nephrotoxin for all practical purposes. So if the patient is congested, why not decongest and reduce one more insult to the recovering kidney? And the whole case I presented, the second case with all those 9 follow-ups, that was essentially your index patient that you're talking about. That's AKI patient on dialysis, had ATN. The patient had pre-existing CKD, so I don't know about his recovery in general. But still, yeah, I believe that we should, there is no reason if you see congestion or if you see something anti-physiology going on, bring it back to physiology and hope for the best.
Okay.
Yeah, I think that's an excellent point, Abhilash. I think there's such a strong culture of giving fluids to AKI, and therefore such a resistance to removing fluids from AKI. A lot of people forget that if you look through the data, what is available even before any of this VExUS stuff is that CVPs above 6 to 8 are deleterious to renal function by and large. And even more so, obviously, if your forward flow is impaired. But there's nothing good about, elevated CVPs or, and even mildly elevated CVPs, even within the goals of fluid resuscitation. Those are essentially nephronocive. So I think it's good to remind people out there that you get back to a normal physiology, the kidneys will be happy. And even if the primary insult to the kidneys is not congestive, decongesting them, in all likelihood will only help.
Okay. All right, thanks. Next question, I think is a spin-off of one of the earlier ones, but so your VExUS, you do your VExUS exam, you've got a dilated IVC. At this point, don't we already know that there's congestion, and what else do the additional windows add?
Yeah, I think, that tells you that, you're essentially at a VExUS 1. So then you have to ask yourself, and so what we found is that, a VExUS 1 is not particularly associated with, a whole lot of terribleness in terms of the splanchnic organs, kidneys, to some degree brain, and probably gut as well. Whereas a VExUS 2 or 3 is. So while a VExUS 1 is, in most cases, a fluid stop point for me, a 2 or 3 is probably a removal point. So I think when you have higher levels of VExUS, of VExUS scores, you're going to have to start to look into helping that congestion more so. While if you just have the plethoric IVC, it probably can be a stop point. Again, you can never look at this in isolation. So you have to look at the whole patient, the cardiovascular, what's the heart doing. But I think that's the added benefit to the gradings of VExUS is that, one might be a stop point, the others may be remove points.
And also in both the cases I showed today, the IVC was still big, right? Even when the VExUS was completely normal, the IVC still remained big, and that might, and I think the question was asked by an internist. So when you're discharging the patients and when you're monitoring the progress, yeah, you can't just rely on IVC alone. And
yeah, it adds a lot more detail, right? It adds a lot more. The IVC is a very blunt instrument. And many people will always live with a congested IVC. So totally agree.
Okay. How about pulsatility of the internal jugular vein or femoral? What are your thoughts about using that? And how do you deal with evaluation of this exam in the cirrhotic patient?
In terms of the femoral, that's been studied. So Dr. Deneau, recently published a paper on pulsatility in the femoral vein, and it does, and it makes sense. It does correlate with congestion as well. So that's been done. In terms of the cirrhotics, what was the specific question again?
It was just, what about cirrhotic patients? I'm sure the technical difficulties in scanning, portal vein perhaps. I'm not sure if they were asking about things like portal vein thrombosis.
Yeah, I can't say I've seen that many portal vein thromboses in cirrhotics to alter my VExUS exam. Most of the time, the cirrhotics tend to be on the empty side, except for the cardiac cirrhotics, who definitely benefit from the decongestion. Yeah, I'm not sure what else I would add to that. Maybe Katie or Abhilash.
Yeah, I don't think we have a lot of data in cirrhotics, right? So I think I have certainly used VExUS in those patients, but I think there's still unanswered questions about the effect of, in the patient with significant ascites, how is that affecting their waveforms if they have increased intra-abdominal pressure? So as you know, I'm going to use it, but it's only a piece of information. And as Phillipe said, most of those patients are so vasodilated that they are emptier and they just have a ton of extravascular fluid. So yeah, I don't have a great succinct answer to that.
That's true. That's what is my impression also. In most of the hepatorenal consults, the heart tends to be like super hyperdynamic with a high cardiac output, and VExUS is almost always like grade 0 or 1. And having a baseline helps, because most of the cirrhotic patients who are admitted to the hospital, especially for awaiting transplant or in the ICU setting, they tend to have some baseline right upper quadrant ultrasounds. So comparing your portal vein waveform from then to the current portal vein might give some insight, because in general we expect that the portal vein is pulsatile at baseline, but in some patients it can just be like continuous at baseline despite increasing RAP. So having that baseline helps. And I try to rely on renal also as much as possible. And mostly I see continuous waveforms in these hepatic patients. But if there is ascites, my first recommendation is to drain the ascites and see if that helps kidney function. And then the rest of the thing comes next.
Does anyone have any thoughts about competency or training related to the VExUS exam? I know there's a lot out there on POCUS in emergency medicine, internal medicine about the different exams. Does anyone use any additional criteria for their faculty if they want to go from the general POCUS exams and include VExUS? Do you require any specific training?
I mean, here in our hospital, we don't. I'm in Canada, like Phillipe, so we don't have like hospital credentialing or anything. In emergency medicine, I guess it's embedded in fellowship, but for internal medicine, cardiology, critical care, so far it's expected to hopefully be a part of training, but that is still very much evolving. So we certainly don't have any, specific formal training that is necessary to do this. But I definitely think that anyone who is undertaking this should have a grounding in basic POCUS and a reasonable understanding of Doppler, because, as we've said in this webinar and in the previous one, like there are a lot of caveats to this and a lot of unknowns. So I think it's important to know enough to know where you can trip up, because that's always the thing with POCUS, and especially an exam like this that can be so finicky and so nuanced. It's important to know enough to know when to stop and when you could get yourself in trouble.
Yeah, I think that like if you are somehow able to show competency in Doppler echocardiography, I think that's good for most hospitals, because it kind of involves your hepatic Doppler also, and that's why the National Board of Echocardiography critical care exam that has helped me get credentials for. They don't ask anything separate for VExUS. That gives credentials for Doppler echo. Yeah. And also, it also depends on specialty, right? In general, in nephrology, you are expected to look at the vascular axis and do some Doppler. So you might have some Doppler exposure from before, compared to a person who doesn't need that much Doppler application. So, yeah.
Okay. Besides Dr. Rola's course that he just mentioned in September, any other online POCUS courses that you can think of offhand?
I think Jacob Avila is doing a critical care ultrasound online course coming up in July that I'm doing a non-VExUS talk at, but I think that one has, I think maybe Rory Spiegel speaking about VExUS. And then, I mean, I think as has been said before, Abhilash has a ton on his website. Phillipe has stuff on his website, Twitter, all the other usual suspects.
Yeah, I think most people want some hands-on experience. I think Cosmos can help us with that. They have some intention of doing that, and let's see.
I think there's just, I think there's somebody, Abhilash, from your site asking about Swan-Ganz catheters versus VExUS. Any studies comparing the two? Dr.
Rola. I don't think so, but yeah. That's my nephrology fellow, new fellow. Very interested in POCUS, so it's for Dr. Rola to answer. As of I know, I don't think there is any comparison, at least like looking at multiple veins, but I'm not 100% sure. Dr. Viska, did you come across any studies?
No, I don't think there's anything. Yeah, certainly not on VExUS, because as we've said, this is so new. The literature on VExUS as a collective exam is obviously so new. Some of the old literature on the hepatic vein and the portal veins have looked at gold standards like a cath to measure, venous pressures, etc., but nothing on VExUS that I know of. Maybe
Yeah.
it's coming. I don't know what Philippe's working on.
Hopefully. Yeah, like the study that Dr. Rola mentioned before, that CVP of more than 6 is not good for the kidneys in the long run. That study is actually a right heart cath based study. So, but I don't think they looked at Doppler. Yeah, I think there are comparisons, like you said, for the individual waveforms, including renal. The latest study on renal venous stasis index, I think it had right heart cath as a comparison, but not as a combination score.
We want to be respectful of everyone's time, and I think we're at the 6 o'clock mark here. I want to thank everyone for participating in this, and for everyone attending, and to keep following Cosmos on Twitter, and that way you can find out when the next webinar is going to be, and to keep following about some of these interesting cases that get posted. All right.
Thank you so much for moderating.
Again, thank you, Cosmos. All right.
Thank you.
Thanks.